well, but past week or two, when we've been doing clinicals, it's come to my attention that we're a touch rusty on EKG rhythms, EKG strips. And since they're going to be on the exam anyway, because of old content, you're gonna get 1 or 2 EKG strips on there every single time. We're gonna do a quick review on it, just to kind of hit the highlights to make sure we're all okay on that. So if I was a good nursing student in Mr. Riccardi's night cohort class, I would probably look at EKG rhythms before this next exam, okay? Then we're gonna get into some neuro. We're gonna do a couple of case studies, hopefully if we have some time, and look at professionalism, case studies, how to overall study for this exam, that kind of stuff, okay? Anybody have any burning questions to start with? Okay. So this is gonna be review. You've seen this lecture before, but it's gonna just kind of hit the highlights, and I will post these EKG rhythms in Canvas probably tomorrow as well. So we're talking about EKGs, and we're interpreting EKGs. How do we go about interpreting those? So first and foremost, we want to look at the rate. How fast is that heart beating initially? We'll count our QRS complexes, see what kind of fast heart rate, slow heart rate, normal heart rate that we have. What's our rhythm overall? Does it look funky? Is it regular? Is it irregular? We'll go from there. Then I'm going to look at my P wave. Remember, your P wave is that atrial depolarization or that atrial contraction when those atriums beat or squeeze. That's going to be your P wave. We have our PR interval as well that we're going to take a look at. Does anybody remember how long it's going to be?
3 to 5 boxes.
3 to 5 boxes, or how many seconds is that?
1.2.
0.2, less than 0.2. Someone wrote that on there. I don't know who did that, but so 0.12 to 0.2 is going to be your PR interval. Anything longer than that, then we might have an issue. Okay. Your QRS complex, that's your ventricular depolarization, or your ventricles contracting, squeezing, pumping that blood. So we'll have our QRS complex there as well. We have our ST segment, that T wave. It's going to be your ventricular repolarization, or your ventricles relaxing, filling up with blood for that next contraction, that next beat as well. Then we have our QT interval at the end. So kind of a step-by-step guide of how I should look about my rhythm, okay? Remember your small squares of your EKG strip, 0.04 seconds. Large squares, 0.2 seconds, or 5 small squares. There won't be one of those math calculations on this exam. So you're good to go, Drew. Here's your just typical EKG strip. Like I said, when I'm talking about small boxes versus large boxes, you have your small boxes here. 5 boxes makes up 1 large square of 1 large box. All right, so let's start interpreting some. Josh, what do I have right here? Asystole, okay. What should I do about asystole? CPR, initially?
Check pulse.
Oh, yeah, check the pulse.
Check a pulse, right? Okay. Hey, are you okay? Check a pulse. Just because the monitor says asystole or you have a flat line, does that mean your patient's in asystole? Not necessarily. Maybe the leads just come undone. If he's up walking around, he's not in asystole, all right? Probably don't even need to check a pulse at that point. Just put his stickers back on him, tell him to get back in the bed, right? So initially, I'm going to check for a pulse. If I don't have a pulse, then I'm going to initiate CPR. I'm going to call for help, get all the things on board. All right, Chuck, what do I have?
AFib.
AFib, you sure? Everybody agree with Chuck? I agree with Chuck. Okay. Anything in particular that I need to worry about with AFib? Clots, okay. Remember, those atriums are quivering, pulling up that blood. That blood is not able to further perfuse into that ventricle. So when we have that pulling or accumulation of blood that gets stagnant, that can form those clots, and then we could further push those clots downstream, causing an MI or a stroke, something along those lines. So if your patient's in AFib, we gotta worry about some anticoagulants. Is this new onset AFib, or has this been a chronic condition? How long have they been in AFib? If I catch it early enough and I see them convert to AFib, I can convert them back out of AFib without having to do some further intervention. If it's chronic AFib, something that I haven't seen on the monitor, or they come in AFib and I don't know how long they've been in AFib, remember I have to get that TEE or some type of echo, a transesophageal echocardiogram to rule out and make sure there's no clots that are kind of circulating in that right atrium. Once I confirm that, that's when I can do my conversion. So I don't want to convert and then shoot those clots everywhere. That's going to be bad news. Okay. What kind of drugs could I give with AFib?
Good job.
Calcium channel blockers, like what? Cardizem, okay, good. Amiodarone's another good antiarrhythmic, I like it. So something like an amiodarone or a cardizem to help control my rate. I get a really fast rate, I get AFib RVR. I can give something like a beta blocker as well to slow it down a little bit to see what we're working with. So how do I know it's AFib? Who said? It's irregular, right? So do my QRS complexes match up every single time? Is there equal spacing between each? There's not. Pretty consistent right there. Got a longer QRS complex right in here, kind of shorter, super long. And I don't have a P wave. Just kind of have this squiggly line to it. So no P wave and inconsistent QRS complex spacing. Gonna be my two big things with AFib. Questions about AFib? No? Okay. Come on. Maybe what do I got?
You have pacing.
We do have pacing, okay. What kind of pacing? Dual pacing, which is also called what?
AV.
I hear AV pacing. That sound right? Atrial and ventricular pacing, dual pacing. So does everybody see these pacer spikes? This is what these are, our pacer spikes right there. So with AV pacing or atrial ventricular pacing, I'm gonna have a pacer spike before my P wave. I'm also gonna have a pacer spike before my QRS complex. So remember, our P wave on our EKG strip shows that atrial contraction. That's where I get that A pace from. I gotta send electrical current through my heart for that atrium to beat. So that's A pace. That pacer spike is making that atrium beat. Remember, our QRS complex is our ventricles contracting, ventricle depolarization. I have my pacer spike right before my QRS complex. I gotta send that electrical current through the heart to make that ventricle beat. All right? So AV pacing. You could have just atrial pacing. You could just have ventricular pacing, or you could have both. Depending on where your pacer spike is, it's gonna determine what our pacer is. That make sense? Okay. Sam, what do I have? A flutter? How you know? Sawtooth pattern, that's a classic sign. So we have this real sawtooth, sharp tooth looking appearance in our P waves. And then your A flutter is gonna have more consistent spacing between your QRS complex. It's gonna be more regular of a rhythm compared to that AFib. Remember AFib, there was the inconsistent spacing in between our QRS complexes. I have more of a regular spacing here.
Are the peak heights relevant at all in this?
Not really. A flutter, very similar interventions, things we need to consider with AFib. Okay. Meredith, what do I have here?
I think
You think?
it's right part.
Not quite. It could be bradycardia, but there's something more to it. Your license, just while I was asking. Anybody else have anything? First degree, okay? So, remember our PR interval is 0.2, or one big box, right, of our EKG strip. So if we look at our PR interval right here, see how it's more spaced out than this one big box? Same here, PR interval, bigger than one box. So I just have a prolonged PR interval. That's the only thing that's wrong with this EKG strip. Prolonged PR interval with our first degree heart block. Nothing else is missing though, right? Got a P wave, QRS, T wave. P wave, QRS, T wave. Am I missing any QRS complexes going across? So nothing's dropping. I'm not losing a heartbeat, anything there. Just the prolonged PR interval. Do I gotta worry about anything with first degree?
Not usually.
Not really. Okay.
Continue to monitor.
Continue to monitor. Good. How about we pick one on over here? Jess, what do we have here? Or I can ask Haley. I'm gonna ask Haley.
Please.
Haley, what do we have right here? They are PVCs, okay? What kind of PVCs?
No, there's two different ways to or no?
Close. You're in the right path. So they are pointing in different directions. There's another term for it. Multifocal, right? Multifocal PVCs. All right, so I got a P wave, QRS, T wave. My ventricle kind of just says, I don't want to beat, so I got a PVC here, or premature ventricular complex. Got a couple normal more beats here, and then I have another PVC. But it's going in a different direction. We have a down PVC, we have an up PVC. So multifocal PVC, all right? There's no such thing as quadgemini, so if anybody tries to tell you that, there's no such thing. There's not a PVC every fourth beat. That doesn't count. That's just PVCs. All right. So there's no such thing as quadgemini, if you hear it. So multifocal PVCs. All right, Jess, what's this one?
Is that normal?
Homosinus. Everybody agree? Yep. So depending on how many QRS complexes we count, we can get between 70 and 80 heartbeats. Do I have all my parts and pieces? Yes, I do. Got my P wave, my QRS, my T wave. Is my PR interval short? It's in normal range like it should. So just normal sinus rhythm. Pretty straightforward on that one. Zach, what do I have on this one?
Is that a third degree heart block?
Not quite.
Second degree, would you?
I'm hearing second degree type what?
Oh, that's right, third degree, they have no relation to each other.
Second degree type 2,
That's right.
okay? So I have consistently long PR intervals, but they're not getting any longer, right? So that's your difference between your second degree type 2 and your type 1. Just to have a prolonged PR interval, but they're not getting any longer. So long PR interval, long PR interval, long PR interval, have a P wave, I missed a beat. No QRS complex right there, okay? So my ventricle didn't contract right here. Atrium contracted, no ventricular contraction, all right? Now I go back to my long PR interval, long PR interval. If we kept going, I'd probably lose another beat down there somewhere, okay? Just a prolonged PR interval, and then a drop beat. And what do I have here?
There's sinus bradycardia.
Everybody agree?
I guess technically there's a sinus valve in there.
Everybody have a sinus bradycardia? We're not gonna interpret this section.
Okay, I was like,
Just right over here. Sinus bradycardia.
Yep.
Got a P wave, got a QRS, got a T wave. Heart rate's technically 30 on this. Is this okay?
I mean, depends.
Depends.
Lance Armstrong is okay.
Well, not-
If it's Lance Armstrong.
Okay.
Because Lance Armstrong, probably so, because he bikes every single day of the week, right? He
Are we
frequents.
under general anesthesia?
Are we under general anesthesia? Are we symptomatic? It's gonna be our other keyword. Are we super hypotensive? Are they dizzy? Are they lightheaded? Are they short of breath? All those things. If they're a runner, someone that's younger, they may have some bradycardia. Maybe asymptomatic, and it's not gonna affect them. Okay. Hannah, what do we have? Second degree type 1 or winky bot? All right, how'd you come to that conclusion? What now? The PR interval got longer each time. I like that. And then we lost a beat down here at the end, right? Okay? So see how your PR interval was kind of so-so? Gets a little bit longer, then we drop. All right? So longer drop, that's a winky bot. Second degree type 1. That's your difference between type 1 and type 2 second degree. Second degree type 1, longer and longer PR interval. Second degree type 2, consistent PR interval. Good. We haven't called on Stephanie. What's this?
Sinus tach.
Sinus tach. Okay. What is sinus tach for us? What's the normal heart rate for sinus tach?
Like 100 to 149, 150 is supraventricular.
Yeah, so 100 to 150 is going to be your, sinus tach. Anything above 150 is going to be your SVT or your supraventricular tachycardia. Anything I got to do about this?
Calm down.
Cool them down, is that what you said?
Calm down.
Oh, calm them down, okay.
Vagal.
Vagal response, all right. We can get drugs as well. Beta blockers is usually a pretty good option. Triple law or something like that. Okay. Who ain't going? Everybody going? Drew, right home?
Yeah.
Drew, what do we got?
So third degree.
Not quite.
Sinus pause.
Here's sinus pause. I like sinus pause. All right. P wave, QRS, T wave, P wave, QRS, T wave. My heart's taking a break. P wave, QRS, T. My PR interval is not prolonged. I have equal spacing in between. So I'm not dropping a beat because I don't have a P wave in here at all, and then no QRS complex. So just, it took a break right here. Sinus pause. Don't really have to worry about this unless this happens more frequently. Occasional sinus pause, nothing to worry about. Could be some type of electrolyte abnormality, stress, anxiety, infection. Might have to get some other stuff on board with that. What is this one, guys? SVT. All right. Remember, anything greater than 150, right? Same type of interventions. Beta blockers. I could cardiovert if I needed to. Synchronized cardioversion. I could also give adenosine. Remember that favorite drug? Basically reboots your system. Yeah, my favorite drug. Those types of things. Oh, not that one, that one. All right, this is a third degree heart block. See how my P waves are kind of acting on their own, doing their own thing. QRS complexes working on their own time. So my atriums and my ventricles are not communicating with each other, right? What do we do with third degree heart block? Normally it's gonna be a Brady type of rhythm, so a 30 beats per minute right here. Can I give atropine with third degree heart block? No, I would probably know that if I were you. Can't give atropine with it, so what are we gonna do instead? Pace them, right? temporary transcutaneous pacing, put the pacer pads on them, get them to somebody, call a physician. You can't live off of temporary pacing. Well, you can, but it's not, ethical, okay? Because they're just continuously getting shocked, so. 3rd degree AV block. Natalie hadn't answered a question. Natalie, what type of rhythm is this?
Torsades,
Torsades, okay. What can we get for torsades?
magnesium.
Magnesium, good. Alright, are they gonna have a pulse with this? No. It's gonna be a form of VFib, multifocal VTAC VFib. They're not gonna have a pulse with this. Say I have a very inconsistent sizing of my VTAC. Kind of goes big, gets small, big, small. That's how I know it's torsades. So initially, gonna check a pulse, not gonna have a pulse. I'm gonna start compressions, get help, and then we're gonna start doing all the other interventions. Best thing for these people when we're in a code type of situation, initiate high quality CPR until other interventions get there. Once I start doing that CPR, that's when I can defib them and go from there. Okay. But start with CPR first. All right. So I got PDCs here, right?
Mm-hmm.
How often are they occurring?
Every 3rd week.
Every 3rd beat, right? So I got a P, QRS, T, that's kind of a U wave, we won't worry about that right now. But P wave, QRS, PVC. P, QRS, P, QRS, PVC. So every 3rd beat, I'm having a PVC. So PVCs or trigeminal. Every 3rd beat is a PVC, trigeminal. I can also have it where it's a PVC every other beat. So I have a PVC, a normal beat, PVC, normal beat, PVC, that's bigeminal. Every other beat. That's gonna be your difference. Pretty standard here, it's regular old VTAC, right? Okay. They could have a pulse with VTAC, so be careful with that, check a pulse. Get compressions in if necessary. If they don't have a pulse, shock them is gonna be kind of your #1 priority, trying to get that on board as quick as you can. Like I said, you're gonna initially do chest compressions, but the best thing for them is going to be defibrillation as quick as you can. All right, and then this is gonna be your VFib, a little bit different. Still the same interventions. Initiate CPR, call for help, and then hopefully defibrillate them soon thereafter. They're not gonna have a pulse with VFib. Last one, this one's an important one. You're gonna see this one often, even in the real world, STEMI. Yeah, so ST, elevated myocardial infarction. So I have a P interval or P wave, QRS complex, as it's coming down into my S wave right here. It's not getting back down to my isoelectric line all the way across, and then it goes right back up into my T wave. All right. You got the tombstone, you got the fireman's hat, you got the sharp tooth, the oven mitt, whatever you want to commit to your memory. But this is a STEMI. When you do an EKG quiz on your initial hire, because everybody will, and you'll probably get it yearly, they're gonna have several STEMIs on there. Okay. Questions about EKG rhythms? Natalie, these are gonna be on the exam, please say. Okay. There's sandwiches in the back if you want some.
How many?
Yep, go for it. Anybody need a break?
I thought that's, I read too quick and I said a stroke overnight and I was thinking. I thought that's what you said.
Where's your mind at?
I just saw stroke and it said, I thought it said 9.
Take 5 minutes. Looks like a couple people are getting up. We'll start back